Hello, welcome to the 2022 version of our first module, and we're going to be covering really just a history of maternal child health and looking at some of the ways, some of the terms and ways that we care for women in this field, in this specialty. I have provided the guided notes down in the notes below. So if you are in class taking this, you may want to use that to kind of pick out the need to know information versus the nice to know information. All right, let's get started. We are using the 4th edition of this textbook, and I do follow it pretty closely. I have combined chapters 1 and 2. Remember, we're changing up how we do our lectures. We are moving from just a lecture-based curriculum to more of a clinical judgment. So I'm going to try to infuse some of those types of ideas and questions in here. And I will have a separate video that goes through case studies specifically. But let's get the foundation down. We always start with the objectives. What are we here to do? What are we here to learn? And this is, you can pause here and look at what I hope to accomplish by the end of the video. So we're going to go on a journey. We're going to talk about the last 100 years or so. And yeah, I've got my doggo tapping her feet behind me. She likes to be part of these videos. So when we look back at history and we see pictures like this of women who were having babies, what do you notice that's different from what you might think of as a modern day delivery? Well, first of all, it's mostly women involved, and the women are in upright positions because that is the natural position that most women will choose to get in if they are unmedicated and can feel. So women have always been with women. That is something that we see as far back as we can get. In colonial America, childbirth was terrifying because so many women didn't survive it and so many babies didn't survive it. And we saw infection rates, and it was truly a terrifying time for women. And unfortunately, as we look at our modern day deliveries, especially here in the United States, it's terrifying again. We actually have a rising maternal death rate after childbirth and the time period surrounding childbirth. So it's kind of interesting to look back, and I have a lot of these infused within the video. This is a NPR section about the wisdom of midwives. Midwives means with woman, and how they knew even from long ago that washing their hands were important. This is even before germ theory came about and was discovered. But women always knew about washing their hands to be with midwives. And as we saw a big shift from the people that were helping care for women, it moved more into the hospital setting, and we moved more into male-centered care providers, and we'll talk why that happened in a minute. We saw an increase in death, and they couldn't understand infection and death, and they couldn't understand what was going on. It was because they weren't washing their hands. The providers were going from caring for sick people on the wards and then coming to see the moms and babies, and they weren't washing their hands, and they were spreading infection, and which led to death. It's an interesting little piece. I recommend it. So as we move into the 19th century, so in the late 1800s and early 1900s, we see that immigration led to increased infection. So now we have more people in a smaller geographical area. Children were viewed as a commodity. The more children you had, it was going to help your family. They would be put to work right away, and they were there to help support the family either on the farm or in the cities. And in that second half of that century is when we really started seeing the advent of public health efforts. And this is a fascinating history if you go back and look at where the safe milk supply programs came from and the early vaccination programs. It's a fascinating look into history. It's beyond the subject of this course, but interesting to see where we've come from. The other thing that happened as we move into the 19th century is, especially after the wars, we had this large amount of physicians that had been created for the wars. And now that we don't have all these injuries and things that we need to be taken care of, we have all these physicians and they don't have a whole lot to do. So they kind of, it was what they call, it was a shift in public opinion, and they were really trying to convince women to come to them and let them care for them during their pregnancy and childbirth. And so they had something, they started terming it. They even used newspapers, and they termed it the midwife problem. So they started skewing public opinion to think that the midwives were uneducated, that they were dirty, that they didn't know what they were doing, and that outcomes were worse with the midwives because we have all this medical technology that can help you. And so this public opinion really started to shift where women felt most comfortable having their babies. And the wisdom that came, the bedside knowledge that was learned from the what we call the granny midwives, the original midwives, a lot of that was lost because they didn't get to bring that to the bedside, and they were publicly shamed for their practices. So it was really a big shift in how women were cared for. We did still have programs to help train midwives. In fact, the Frontier Midwifery Program, Midwifery Service, it was started in Kentucky, and they actually started a training program where they would bring new midwives in and train them. And this is still in existence today. This is the oldest nurse midwifery program in the United States and still in existence today. It's more community based now. And a lot of our current practicing midwives have actually come from this school. There are several other schools as well, especially as we start to tackle the problem of not having enough providers in the next dozen years or so. They're really encouraging the use of midwives and the training of midwives. So we're actually seeing a comeback, which is phenomenal. And I'll explain why in just a minute. So in 1900, this is just a fun fact, less than 5% of women gave birth in hospitals. That's just not where we went to have babies because we weren't sick, and that's where sick people went. In 1935, about 37% of births occurred in hospitals. So there you start to see that shift. And then in 1950, 88% of births occurred in hospitals. And I think, depending on the resource, somewhere between 3 and 5% of babies are being born outside the hospital now. So how did this big shift happen? Well, there was something that they billed as Twilight Sleep, and they this was actually the 1914 newspaper, and it was a dawning of a new era for women. And this is where they told women that they could provide them with a painless childbirth. And the way they did that is they gave them a little drug called scopolamine, which is an amnesiac drug, and large doses of narcotics. And they forgot the experience. Rather than it being painless, they just didn't have the experience of being conscious of it, remembering it. So I'm going to show you some pictures, and they might have some be a little rough for some people to watch, but there's going to be some pictures, actual pictures of what it looked like during twilight sleep. And this, look at the span here, 50-ish years of twilight sleep to convince women this is where you want to come and have your baby. So this is what it actually looked like. They were put in restraints so they didn't injure themselves. They were blindfolded because they thought that would help them calm down. They were strapped to a table, and these are 4-point restraints, and, quote, delivered of their child. This is what it looked like. These are leather restraints. This is somebody under scopolamine, twilight sleep. This is what the delivery room looked like, where the physician, male physician, would deliver them, usually using forceps. By the way, we don't do this to babies anymore. We don't hang them upside down. I know that's kind of in a lot of the popular culture type movies and stuff, but we don't hang them upside down. They've been all curled up, and this doesn't feel good. I think they were probably had the idea that that helped them drain their fluids, but we don't do that anymore. Anyway, this is what it looked like. So it wasn't painless. It was, you just didn't remember this horrific experience. And this is before the time that partners were invited into that space. So there was no witness to this. So for many of you, maybe your grandmothers or your great grandmothers experienced twilight sleep. So have a conversation with them. Ask them what it was like when they gave birth. As we continue on into the 20th century and through the 21st century, we now have safer cities, we have our vaccine programs, we have a decreased threat of childhood diseases because of those vaccine programs. So there was a time in the recent past where we didn't even think about things like polio anymore or measles because we had a vaccine that almost eradicated those diseases from existence. Unfortunately, with in the last 10 or 20 years, we've seen a big push back against the vaccine idea, and those diseases are still around, and they're actually coming back. Unintentional injuries surpass disease, which is interesting. So now we're moving from things that were just a part of life that we just expected for children, and we're moving away from that, and now it's accidents. And we have increased survival rates. Now, some of these increased survival rates with these accidents or diseases caused chronic disabilities, but we're moving in our technological advances to be able to treat those. In the 1950s, we look at a big shift in how we felt about childbirth, and we can thank this book. This really started the whole process. Thank You, Dr. Lamaze was written by a woman who really felt like she wanted to experience childbirth. She didn't want to do twilight sleep. She wanted to understand what her body was going through, and she felt like her body was made to do this. And so she learned some of these, today we would call them self-meditation or mindfulness practices, but she really learned some relaxation techniques through Dr. Lamaze, and was able to have the birth that she wanted. And then that kind of evolved into a husband coached childbirth, which was the Bradley method. And we started to see that in the 60s and 70s and 80s. And this is where husbands were invited into the birthing room, and not only just to observe, but to actually be part of the process, because after all, it's the birth of their child as well. Unfortunately, this is what the delivery room looked like in the 1950s and 60s. Still very sterile, very medical, very uninviting, I would say. This is what we did with our babies. They went to a nursery, and they typically stayed there for 4 hours, and they were, quote, sleep trained or schedule trained. So like this little one over here in the corner, this one's saying, I would like some attention. Something's going on, because babies cry to give us the information, right? So this one is saying, whatever is supposed to be happening right now is not how I feel. But they didn't respond to these babies. These babies were kept in the nursery for 4 hours, and if they were starving, they would just cry it out and then taken back to their mothers every 4 hours. I actually saw a picture of a little drawer that was built into the wall of the mother's room, and on the other side of it was the nursery. And so the nurse would just put the baby in the drawer and slide it into the mother. I can only imagine if that was a prime way of getting mixed up babies, right? So this is no longer the practice. We don't have normal newborn nurseries for the most part. There are some places in the country that may still have one, but we don't routinely take babies out of the rooms. They stay with their parents in the rooms. So then we come to what I like to call the revolution. 1960s and 70s, where we saw a huge upswing in home birth again, prepared childbirth, the dads are invited into the rooms, And we really saw a comeback of a nurse midwife and what we call a traditional midwife, or sometimes referred to as a lay midwife. So this is actually Ina May Gaskin and her husband Stephen Gaskin, and they started a commune. And when you get a bunch of men and women together in the middle of the 60s and 70s, you start having babies. And so she is an icon in the midwifery world. She is what we call a traditional midwife. She doesn't have any formal training. She has since earned a doctorate, an honorary doctorate. But she learned things by observation, and she wrote this book, and this is kind of a cult classic, spiritual midwifery. And fun fact, this was the book that was on the library shelf when I was learning about birth with my first pregnancy. And so this really influenced me, because I thought if it's on the library shelf, that must be mainstream, right? Well, it certainly wasn't mainstream, but that is what influenced me. And then come the 60s, where we started having the opportunity to control the amount of children we had in our families. And before this time, I know this is unthinkable to most people nowadays, but there was a time when there wasn't a real good method of controlling birth, that you got married and you got pregnant. You probably had babies every couple of years, and that was just the norm and the society expectation. But then the birth control pill came about, and women decided to have less children or no children. They moved into a career idea, more career focused, where they could actually go out and support themselves. And it was a unique time. Just to put things into perspective, in the year I was born, 1971, it was not allowed, my mother was not allowed in that year to have a bank account unless her husband approved of it and was a signer on it. That was the only option. So just think about how far we've come in the last 51 years. Okay, so here's a picture of how midwifery is taught. It's a lot of hands-on learning from an experienced midwife. There's Ina May again, and this is actually a picture of her at the farm, where in Tennessee, which is the commune that I talked about, where they still train midwives today, and women from all over the world come to have their babies there. If you're interested, just Google the farm and learn all about it. I really love the quotes that come. She still does talks. I just listened to one not too long ago, and she has some really amazing quotes. And she says, "We're the only species of mammal that doubts our ability to give birth. The only species of mammal that doubts our ability to give birth." Why do you think that is? Why do you think we doubt our ability? Is it because we've been told that our bodies can't do it? Is it because we've been convinced by what we see in on social media and in our movies and our videos and that sort of thing, that we need help to do it? What about those stories that you see in the news sometimes about the magic taxi cab driver, Uber driver that delivered the baby on the side of the road? Who actually delivered that baby? It was the woman that delivered the baby. And was she able to do it without anyone there helping her? Why, yes, she was. So it's just a mindset that we've been convinced that our bodies don't work. And I implore you to go back and look at some of the people like Ina May and the writing. She's written several books. There are lots of good authors out there that talk about trusting our body. So it's profitable to scare women about birth. So true. Let's stop. I tell women, your body's not a lemon. So if you're interested in this, obviously you can see I'm very interested. I've spent my entire adult life learning about it, studying it, looking at it for fun. The PBS series called The Midwife is a fantastic look at childbirth in the 1950s and beyond in East End London. It's beautiful. Like I already mentioned, anything written by Ina May. Penny Simpkin has also written some really great books. If you're going to be in a birth, either as a partner or as an observer or as for any other reason, you should really look at the book, The Birth Partner. As a labor and delivery nurse, the Labor Progress Handbook is essential reading. And then there's an entire video list that I've provided in my Canvas course, and I can drop it in the notes below of this as well, of just other things that are fantastic, other readings that you might be interested in, and videos. So I want to kind of talk about this aha moment that I've had in the last few months, and just introduce this because I'm going to infuse this in my 2022 updated version of all of my lectures. And I think we really need to be talking about, I know we need to be talking about this more. So implicit bias or unconscious bias is biases that we don't know are happening. And when I first started hearing about this concept many years ago, I was really insulted because I felt like people were trying to tell me that I had racist tendencies. And that isn't what this is about. So if you look back into our history, look back into our evolution, when we were standing at the watering hole as early primates, right? We were standing at the watering hole and looking across to other people, other humans at the watering hole. We needed to know pretty quickly, are they our enemy or are they our friend? And so we learned in our brains to start categorizing other humans by what they look like. And that has continued on up to our modern day man. Now it's a very primal, down deep in that deep brain idea, right? So we have a need to belong, and we have a need to understand, are they our friends or are they our enemies? And so this is where that unconscious part comes from. And we do have some biases based on our lived experiences, by our upbringing, by what we see in the media, by what we've been taught, by sometimes our religious affiliation. And so a lot of these things have been, we've been influenced throughout our lives. So there are times when maybe you hear a short S-bar about a patient and you immediately start to have a bias and you might not even recognize it. So for instance, if I tell you that our patient is 17 years old and she's here having her second baby, does that bring up any feelings for you? Do you have biases about that? Do you feel a certain way immediately? Do things start coming to the surface? So what I'm asking here, and again, this was an aha moment for me, is that one of the things we can do is just self-evaluate. Do I have a bias about that? And is this going to affect my care? And this is just something that we can constantly check ourselves on. What if I said this is, we're getting a transfer from a home birth and she's coming in and lots of things are going on with her? Does that give you bias? Do you have bias against somebody who chose a home birth? And we're going to talk more about that in a minute. So I'm just introducing this here. We're going to be bringing this up quite a bit because, as I already mentioned, healthcare, maternal child health care, especially for women of color and indigenous women, has gotten less safe in the last 20 years rather than more safe. And a lot of that may be directed or stemming from unconscious bias. So we'll talk more about that. So here is just another little idea jogger where when we look at stereotypes, when we try to classify specific groups, right? And then that implicit or unconscious bias is our attitudes, maybe towards those specific groups. And then microaggression is when we are really looking at little subtle verbal or nonverbal insults, denigrating messages. Sometimes they're really committed by well-intentioned people who are unaware of the hidden messages. So I'm really trying to check myself as I learn, because this is not something that I already knew, but as I learn more about those microaggressions, I'm trying to change my language and really just address these things head on. Okay, So as we continue on into our look at our current childbirth practices, what we see now in our modern day society is that it's increased technology, threats of litigation. Labor and delivery is one of the highest litigated specialties, unfortunately. I read a statistic once that if you work in labor and delivery for 20 years, you will have gone to court at least twice, or at least done a deposition. We have this time constraint because we've got to get them in and then get them out in order to make money. For the profits to continue to flow, we've got to get women in, get them delivered, and then get them out. Economic restraints. We do not have staff available. We do not have resources available in a lot of places. There are some entire counties that don't have maternal child health care, and women have to travel. And it's definitely contributing to the issues that we see in maternal child health. So, just for instance, on this picture, this is how we are used to seeing women give birth. How does this compare to that picture I showed you earlier about women in an upright position? Do you think there's any benefit to a woman being in an upright position to deliver her baby? Is there a benefit to this position? What do you think? Maybe you could just mull that over for a minute, but I am going to tell you that upright position, gravity helps. It allows that baby to navigate that pelvis, and gravity helps bring this baby down and out. In this position, the woman is actually pushing uphill at one point as this baby starts to navigate the pelvis. And this position was created way back when we convinced women we moved birth from home into the hospital setting because it's very easy for the provider to see what's going on. So this is a provider-centered position. I'll just leave you with that thought for a minute. Here's another little fun website that I highly recommend you go to. It's Rebecca Decker. She's a PhD RN, and she does a lot of the current evidence that we are really doing a deep dive into the things that we have made standards of practice, but aren't based on evidence. And so in nursing, I know you already know this, but in nursing, in medicine, we want to do best practices based on evidence, not just unit practice or provider preference. It needs to be based on evidence. And so just take a little gander at this graph and see all the things that are common in US care that are not supported by the evidence. And all of this can be found on the evidence-based birth website. So when we think about providing good information to people so that they can make a decision, we really look at the differences between absolute risk and relative risk. And so if I say it's riskier to have your baby at home, that puts an idea into their heads versus if I said out of 1,000 people that have their babies at home, one person might have a problem, might need to be transferred. So it's when you look at absolute risk, I think it gives people a better idea. And this is a little graph that you can get online that you can utilize to really explain how the risk might affect people. Because I'm going to wow your mind with this, but when people have choices in healthcare, and as a provider, we are tasked with diagnosing, like discussing what the problem actually is, kind of naming what's going on, or naming the procedure, or naming what it is that they came to us for help for, and then giving them options. We want risk and benefit of each of those options. And then by using shared decision making, we allow them to make the decision that's right for them. Have you had the experience in healthcare of that? I have not. That is not the healthcare that I'm used to. And as a future potential provider, that is the kind of healthcare I plan to provide. So this is what a modern hospital delivery room looks like. They kind of changed the hospital rooms. Oh, this happened about 30 years ago to really convince, to make people feel more comfortable and have a more home-like atmosphere. very quickly, this hospital room can turn into a high-risk medical center. It's got oxygen and suction piped into the wall, and this is a warmer that we can warm the baby up and do full resuscitation on. This bed breaks apart for easy delivery. So this is what a modern day room in some form or fashion usually looks like. Most birthing rooms, I hope, are private nowadays. It used to be that they were on wards and they shared space, but now most rooms are private. This is what it looks like in a home environment. So the people that you want to be in that delivery are invited by you. Yes, these can be rented. Home environments are often attended by either a nurse midwife or a traditional midwife or a licensed midwife. There are several different types of midwifery. The only type of provider, only type of midwife that works in a hospital is a nurse midwife. Sometimes you'll see other providers. There are some family practice doctors around that will do home birth as well. And it's just a different environment, right? Just this is you're in your own space with the people that you want to be there. So when I ask, here's a potential bias: is home birth safe? What do you think? What have you heard? Have you had conversations about it? If you ask again to your mothers and your grandmothers, maybe you'll be surprised who's had home births or what they think about home birth. We go back to the evidence, and again, we are going to look at the most recent studies. So there was one that was from 15, that's a little bit old now. They looked at 79,000 birth records, and the risk of intervention was definitely higher in hospital birth, which makes sense, right? And the limitation of this study was they couldn't decide who was being transferred from a birth center outside the hospital or a home setting. So that was really a limitation to the study. But using our absolute risk versus relative risk for care option A, home birth, there was a 3.9% risk of, I think there's a risk of transfer. I actually can't remember now, or risk of severe intervention. And then for care option B in hospital birth, there was a 1.8% risk. And I am trying to remember exactly what that risk was. Over here, we looked at a more current version. And again, you're looking at 500,000 deliveries. So that was a lot of home births that were intended. They were meant to be at home. And what they found was that the odds of a perinatal or neonatal mortality was 1.07 and 1.08 if they had had babies before. And so it was not different than the hospital. And so what this is really telling us is that if there's good communication between the home birth team and the hospital team, if transfer happens smoothly in those rare events of emergencies, it's no less safe than a hospital birth, and that the risk of intervention is much greater in the hospital than it is and sometimes that can be a cascade of events. So my whole point of this was, if we're looking at something that we have a bias about, there might be new information that we need to go back and take a look at. And that's really, I want to implore you as nurses that we never know everything, and that science is evolving and changing all the time. And that one way that we learned something maybe 3 or 4 years ago, best practice may actually be different now based on new information that has come up. So we are always learning. That's one thing I can say in my life, is that I have been a lifelong learner, and there's always something more to know. In fact, the more I learn, the more I realize there's so much more to learn. So where are we today? Depending on the statistic, we might have a little bit different range here. All of our different resources might have a little bit different ranges, but the essence of this point is still there. Our primary cesarean deliveries this is a category that should be the least likely to have a cesarean. This is nulliparous, meaning they've not had a baby before, they're at term, They are a singleton, and that singleton is in the vertex position, so head down position. So this is the group of people that should be the least likely to have cesareans. And in our society today, this group is 25% of them are having cesareans. So that's 1 in 4 of them are going to have a cesarean birth. And the WHO, which is the World Health Organization, recommends that we, as a society, we should really only have about a 15% of primary cesarean sections in that population. So we're doing something wrong, right? All cesarean deliveries, so this is repeat cesareans as well, is at 31%. So that's a third of all women giving birth are giving birth by cesarean section. Why is that a bad thing? Well, the point I'm trying to make is we have moved from normal physiological birth and low intervention and recognizing that for the most part, birth is a normal physiological process and turning it into a medical procedure and a high intervention medical procedure. And we will talk more about that as we go through this series. 2% of babies are born outside of the hospital. Less than half of a percent attend any sort of childbirth education. And I think this is just from my own experience. A lot of people don't go to childbirth classes anymore because they sometimes are called Lamaze classes, and people equate that to birth without pain relief. And that's not what we do in childbirth education. In childbirth education, we're talking about what the process is and what's normal and the physiological things that are going to be happening so that you know what to expect. We also talk about the pain medicine options. And so there's so much more that we learn about in childbirth education, but it is just not appealing to this generation. So what needs to happen is we need to make it more accessible. It needs to be online. There needs to be YouTube videos. There needs to be apps that infuse that education in throughout their pregnancies, and then we will get more people educated. And about 2/3 of women receive an epidural or a spinal when they are delivering their babies, which is a pretty high number. And in some cases, it's actually more like 90% of the deliveries that are happening. And that depends on the culture of the facility that they're delivering in. So in the United States, we are the most expensive country in the world to have babies. And so you can see here what our rates are. And these numbers are a little old, I think. Yeah, so this 2017, I bet they're double that now. But looking at all the other industrialized countries, looking at those rates, now they have some differences in their insurance, and we'll talk about that. But we're the most expensive country in the world to have a baby. We should be the safest, right? Unfortunately, that's not the case. So when we talk about mortality, just to remind everyone, that's the number of people who have died over a specific time. And when we're talking about maternal mortality, that is the number of people that have died during pregnancy or within 42 days of the end of the delivery, or 42 days of birth, whether that be a termination or a live birth. Okay. So in the United States, rates for African American women are higher than any other ethnic group. And overall, as a whole, the US ranks 46th in the world for maternal mortality. I'll let that sit there for just a minute. 46th. And here's a fun little graph. Here we are down here. And all these countries do it better than we do. All of them. And some of them are, you wouldn't expect that they would do things better than we do, but they do. Just take a look at some of these countries and really compare where we stand versus where they stand. And this graph has really been spread a lot. It came out of the Lancet in, I can't remember what year it came out. I want to say 2016. But it really looked at all of these countries have decreased their mortality rate since the year 2000, the maternal mortality rate, while the United States is steadily rising. So why is that? What is going on that in the United States, we have an increased maternal mortality rate, that Indigenous people and women of color have sometimes 3 or 4 times higher mortality rates than white women, What's going on? What can you possibly equate that to? Is it perhaps, and there's been a lot of discussion over this because this is an embarrassment to our country, and it's a shame on us for not taking better care of our women, our birthing people. Is it unconscious bias that's contributing to it? That's part of it. That's part of the experience. This is a really great article that is looking at addressing implicit bias in maternity care. Highly recommend going and checking this one out. And there have been a lot of initiatives to try to decrease our maternal mortality rate for specific groups. And so this was actually put together, I think it's on the next slide here, by the hospitalist group. And I'll let you spend some time looking at this and really just bring those numbers to home. So remember I said absolute risk versus relative risk. Well, let's put this into perspective. 700 women each year in the US are dying after having a baby or around the time that they're having a baby. 700 women aren't going home, and sometimes those babies survive without them, and they're not going home to their families. 65,000 experience life-threatening complications. We've seen a 26% increase, and US women are dying at a much higher rate, as I've already showed you. African American women are 3 to 4 times more likely to die. 83% of maternal deaths do not occur on the day of delivery. It's leading up to it or after it. And 60% of those deaths can be prevented. So I'm bringing this to you because you are the next generation of healthcare providers that are going to care for our women. And we have to address this situation. This can't continue down with this upward swing. We've got to turn it around and fix this problem. I've seen this over my 25-year career. And back in the day, it was so rare to even think about a maternal death. And unfortunately, we have to add it to our curriculum now and discuss it. So lots of options for a care provider in the United States. We're going back to the idea that the United States is the most expensive place in the world to have a baby. It is not the safest place in the world to have a baby. We have lots of options for providers, except that in some places we don't have options. So for instance, in where I am, in my geographical area, we do not have any practicing midwives in hospitals. We have no nurse midwives practicing in hospitals. And so we call that a midwife desert. And in some places, there are no care providers whatsoever to care for women, and they have to travel sometimes hours to be able to get the care they need. So when we're looking at the differences between the medical model of care, which is traditionally OBGYN, obstetrician, gynecologist, who is a surgeon first, by the way, versus a midwifery model, you can see that there's some big differences in how we approach the care of physiological birth and supporting physiological birth. And the big difference is the medical model, pregnancy is only normal in retrospect. You've only proven that you have a normal pregnancy when it's all over. But in the midwifery model, we respect the process that for most people, pregnancy and birth are normal physiological processes and don't require a lot of intervention. So I've talked a little bit about this already. This is what we like to call the umbrella of patient-centered care. And this idea came from a professor of mine. And really, when we think about, we've learned a lot about informed decision and informed choice, right? Well, it's all of this has to happen. Women have to have access to care, and they have to feel respected, and they have to want to come to that care. And then they come to us for shared decision making so that we can help them decide, we can give them options, and then respect the decision that they have made for their care. And motivational interviewing is really helping them to make the best choices. Instead of saying, oh, you're a smoker, you shouldn't smoke, exploring why they're smoking and are they motivated to stop smoking after they've been given the information about why it's not best practice to smoke while pregnant or with a young baby. So I'm going to infuse this idea into a lot of the lectures as well. This is just kind of a glimpse into where into my mindset of where we need to go in healthcare. And so this is the big point I was trying to get to. I already mentioned that the United States, it has some issues. And here's what we see, the big differences between us and all those people that are doing it better than us is they have more midwives. Midwives are the answer. Midwives support normal delivery. And here you can see all of these countries, this pink line here is the amount of midwives that are used to take care of their patients versus OBGYNs. And what do you notice down here? There's more OBGYNs than there is midwives. And does that have to do with our for-profit medical healthcare system? Probably. Does that have to do with that whole shift in our society views in the last 100 years that I talked about early in this lecture? Most likely. Does that have to do with a technology-centered, profit-motivated system? Most likely. So 85% of women who birth in hospitals are considered low risk. And 100% of those women are candidates for midwifery care. Can you tell that I'm totally on the midwifery train? Yeah. Okay, CDC reported 86% of births were attended by physicians and only 8% attended by midwives. So here's a big announcement. More midwives are going to help solve our primary care crisis that we're heading into for women's health. So if any of you are interested in becoming a midwife, I implore you to just search it out. In fact, the United States government is put together a blueprint on how we're going to fix our healthcare system. And part of it includes educating more midwives and providing the funds to help in that process of that education. So check it out. Here is another podcast, evidence-based birth again, and she talks about the importance of having care providers that look like you, that understand your culture, that understand the nuances in that community group, and it's really a powerful podcast. Okay, so moving on, we are looking at fetal mortality. So this is the number of fetal deaths 20 weeks or older, and it's actually higher than you would imagine. We have some factors that kind of play into this: malnutrition, disease, preterm cervical dilation. We'll get more into that in our next few modules, but this is often overlooked as a public health problem. So this is somebody that's gone halfway through their pregnancy and then their baby dies for some reason. And we call it a fetal death or fetal demise. And it's the part of labor and delivery that we don't talk about very often. It's not the part that really brings you into wanting to be a labor and delivery nurse, but we care for these women as well. And in our next few lectures, we'll be talking about how we do that. And then our neonatal mortality rate is our number of infant deaths in the first 28 days of life. And we see congenital anomalies sometimes, as the leading cause. And then low birth weight and prematurity, which is a significant predictor of infant mortality. So those are those early preterm deliveries. And both of these statistics are not where we want them. So we have a lot of work to do in our country to help change the care that women receive. Healthy people are 2030 are national goals that we set to try to improve our health around certain populations of people. So our population we're talking about is maternal child health. And here are some of the goals they've set as a nation, and that's really to improve health equity, meaning everyone has access to healthcare, and to improve health literacy. What does that mean? And help them take responsibility for the things that are affecting their health. So other things that will affect maternal child health is genetics. Obviously, that is not something that we can control. Your family culture, your lifestyle, access to healthcare, we've talked about a lot. We're going to spend a lot of time talking about social media and society in just a minute. Empowering of the health empowerment of the healthcare consumer. Like I was just saying, we have choice and we don't know that we have choice. And it's a very paternalistic environment. And sometimes people, especially those with lower health literacy, don't feel like they can make choices. They feel like they have to do what is presented to them. All of these things can either positively promote growth and development or negatively decrease the health and development of our families. So big things that big concepts here, we want to increase the responsibility for their own health care by giving them choice, by increasing their health literacy, right? We want to increase their participation in the decision-making process. That's that under that umbrella that I showed you of shared decision-making. And then really respecting that they have choice, even when it doesn't agree with the choices that we would make for ourselves or our children. I think that is one of the biggest, I'm just going to say, problems in our society, is that for some reason, each of us, some of us, feel like my decisions are the best decisions, and I want to put them on you and make you make the same decision I would make. And that is just not how we get along. Okay, so I'm going to leave that there. Here are some barriers to healthcare that maybe you might not think of. A lot of times when we think of barriers, we always think financial, either limited or no health insurance. But what about a woman that has the ability or has insurance to cover her prenatal care, but she has to travel 2 hours on a bus? She has children, other children that she either has to bring with her or has to find childcare for, and then she has to wait for hours in a waiting room in order to access that care. That's not really access to care. And or if she arrives at that waiting room and she's told, no, your children can't be here, or she arrives at that waiting room and she's judged for something, either her culture or her religion or her immigration status or her language, and she doesn't feel welcome. So those are other barriers that keep people from getting the care that is available to them. So enculturation is an idea. What does this mean? What do you think enculturation might mean? It is what our culture, how it influences how we see society, and it influences our beliefs. So for instance, how do you think these women feel about breasts? Do you think that they are ashamed of them? Do you think that in their society, maybe they're viewed as natural, normal, part of their anatomy, that they're there for feeding babies? How do we in the predominant United States culture feel about breasts? What do we think about them? Well, we think they're for selling you things, right? We use them for advertisement because we have sexualized the female breast to convince you to buy things. What about this one? That was an ad, right? Remember that one? What does this tell you? It tells you that the human female body sells. And that's what this is about. What are breasts really for? What are they designed for? Why are they there? Well, in some cases, they're there to feed a baby, right? It's not what everyone chooses to do, but that is their purpose, one of their purposes. How would you feel about this on a billboard versus this on a billboard? Let you think about that for a minute. Okay, now we're going to talk about social media. I think social media has the potential to be phenomenal for healthcare because we have the ability to put information out there that maybe people didn't know in an easily accessible, small chunk type of message, right? Like TikTok, for instance. Those are fantastic ways to learn things. But here's the problem. anyone can put anything out there. And then it can influence an entire group of people. It can influence an entire generation. Here's an example. So placenta faggy is the act of eating your own placenta. And it was really brought to mainstream society by this social media influence. She talked about how she did it and convinced everyone, all the health proponents, that it serves. Now, unfortunately, those health proponents are not proven by evidence. Now, there's a lot of research still going on about this, but some of the things that it is purported to do, like decreasing depression and increasing your milk supply, just purely has not been proven in the evidence. There's no current evidence that tells us these things are backed up by science. What we do know is that we can spread infection and disease by eating the placenta, even if it's been, quote, prepared by the people that are trying to sell you this process. And so what the most common way is they will boil it and then freeze dry it and then put it in capsules and give it back to you. This is a multi-billion, yes, I said $billion business. So of course they're going to advertise it, right? So my point here is we have to always fact check and look at what does the evidence say. Now, it may be, we might have some evidence come out and say there are benefits to doing this. But at this point, we do know babies have been infected with group B strep, which is a bacteria that we'll talk about later, from maternal consumption of dehydrated placenta. So we do know that it spreads infection. What about this one? This is a hot topic right now. So this is in the 1950s when the polio vaccine was mass provided to everyone. And this man is in an iron lung from polio. This polio is rampantly contagious. And I've actually been teaching this lecture for a long time. And I cannot believe I'm about to say what I'm about to say. I never thought we would get to this point. Polio is back. As I am recording this lecture right now, we're having an outbreak in New York, and polio is one of those diseases. They have already found it in the wastewater. That means that there's community spread, and it's one of those diseases that is hugely rampant and easily caught. And 1 in 4, I believe, is the statistic of people that get polio will have paralysis or something that happens later, what they call post-polio syndrome. My grandparents were around during the time when the polio vaccine was just being started. They were adults at that time. And my grandmother did catch polio, but she didn't have any lasting effects of it. And they could see the polio infection come down the street, like the person on the corner got it, and then the next house got it, and then the next house. Like it was terrifying for them. And how did we get to this point from having a very effective vaccine that can stop the disease in its tracks and almost eradicating it off the face of this earth to talking about a new polio outbreak? It's because of social media and the talk about vaccines and the politicalization of vaccines. So we need herd immunity to keep these infections at bay. And that means enough of us have to be immune to it so that it doesn't have enough hosts to spread through. There was, in 1998, a study based on 12 people that was funded by a vaccine injury lawyer. You may have heard about this. It was by then Dr. Wakefield. He has since had his medical license removed. And what this study talked about, you can go here and look at it, what this study talked about was the connection between vaccines and autism. Again, this was a sample size of 12, and it has since been retracted. Wakefield fudged his numbers, his evidence. He faked his research and lost his medical license over it. But this has influenced an entire generation of people against vaccines. They have since done last time I looked, there was over 700 different studies proving that there is no correlation between autism and vaccines, but that one study is still prevalent and people still talk about it. So this is the danger that we risk when everyone's allowed to discuss medical things on the internet. We see measles outbreaks because people have stopped vaccinating their children. That they have decided, without good advice, that the risk of the vaccine is worse than the risk of the disease. And the problem with this idea is, in our recent memory, we don't remember what it looks like to have a measles death because there's not enough measles to go that's circulating around to show us those death numbers. But measles can kill. Polio paralyzes and can kill. But we have lost that in our recent memory. I don't even know what the signs and symptoms to look for these diseases because we haven't had to teach them for so many years. So this is really the danger of fake medical news. And so I spend all this time talking about this because as a healthcare provider, you are responsible to call out the fake news when it comes to medical stuff. You are now the keeper of your social media circle. When you see somebody that starts to circulate something that is not true, one of two things is you can report it so that it gets taken off, or you can refute it by giving the actual science. Not going to make any friends doing that, but hopefully we can save some babies. This is what it looks like to be on a vent from whooping cough, pertussis, which is also in our, we have vaccines for. This is what polio paralysis looks like, and it doesn't get better. So evidence-based care is really where we need to be focusing, and we need to use our resources to determine if it's evidence-based care. Now, having said that, I have a whole nother video talking about what's a good resource. How do you know it's a good resource? And we apply a concept to it to determine if it's a good resource. So as a clinician working in the hospital, as someone caring for patients, we should be making decisions based on the best scientific evidence of the time, not of 20 years ago, but of the time, based on their values, the client's values and their preferences. So they may decide to go against the best scientific evidence, and we need to support that. We need to look at each individual clinical circumstance and not apply something to an entire group, like laboring women, based on one issue that may be happening over here to a certain population. And we can bring in our clinical expertise. Now, having said clinical expertise, when we're in labor and delivery, especially my students that are going to be with me in clinic, we never talk about our own personal experiences. And it's really easy to do in labor and delivery because a lot of us have had babies or raised babies, right? But I feel, it is my opinion, that it is not appropriate to talk about our personal experiences. We can talk about what's right for the patient and we can talk about what's current, but leaving our personal experience out of it, I believe is the professional way to do it. So here's the crap test that I was talking about. This is what you're going to apply to any resource to make sure that that resource is factual and not fake. And so you can read through here and see, when was it written? Is there an author? Does that author have experience, or were they just paid by the word? And that does happen. Are they trying to convince you of something? If they're trying to convince you of something, most often that is fake. And you have to know that before you start spreading that. Here's a classic example. Stop the video, go to Google and type in anything to do with childbirth. Type in epidural. And one of the first hits you're going to find on your Google search is going to come up from AmericanPregnancy.org, because they paid Google to be their first hit. Are they an expert in that field, on that subject, on that topic? Probably not. Look through and see who wrote that article. It may be someone that was just paid. So anything from AmericanPregnancy.org is not necessarily fact. You want to go and look and see who the author is, what their experience is. Is it based on current evidence? Now, there might be something in there that is based on fact, but be leery that they paid to be the first hit you get. Okay. Okay, we're moving into chapter 2 and talking a little bit about caring for women in this field. And this is also going to move on into other patients as well. So this would cover your pediatric patients as well. Some need to know information is what are the things that fit in the preventative care? Because really, as nurses, our job is to educate about preventative care. So these are all things that fit in primary prevention. And then we have secondary prevention. This is early detection and treatment of things that are adverse health conditions. So these are your things like your health screenings, okay? And then tertiary prevention is limiting the progression of the disease or disability. So knowing the differences between those three is need to know information. Complementary and alternative medicine, you're going to see a lot of this utilized, especially in the maternal child health arena. Our job, what is our role in this, is to make sure, we're just here to make sure that whatever they're using is not going to interfere with the medical treatment that we are providing them, the traditional medical treatment. So for instance, if they're taking herbs, we need to make sure that those herbs are not going to interfere with what we might be giving them. And so that's really our role. Our role is not to convince people that these do or do not work. It's just to make sure that we can integrate them safely. And then collaboration. We do a lot of collaboration with lots of other members of our team. And ideally, labor and delivery, postpartum, and neonatal intensive care nurses work cohesively as a team, but those are all very different specialties with very different goals. And so sometimes you see a little not working well together because they have different goals in the patients that they're caring for. So integrating these three specialties is very important. We also work closely with social services and potentially with case management and mental health services in labor and delivery. And communication. So when we are talking to a patient, here's another big moment for me. I have asked women very private questions for years, just asked them as part of my initial assessment. And I don't really have a right to know that information unless I've been given permission. So my new process is asking to ask. Is it okay if I ask you some really personal questions? And the reason I need that information is so that I can either decide what assessment needs to happen right now or decide what path we need to go down to collaborate with our physician. So asking to ask is one of those ways that we can respect people, especially people with trauma in their history, respecting that they don't have to tell me everything, that knowing that that what they're about to tell me is obviously personal and private, and I need to hold that. We do something called a bedside report, which is part of our best practice when we do a handoff to another nurse. And there may be other people in the room that don't need to know her entire pregnancy history. And so we have to be very careful about the things that we say at that bedside report. Our verbal and nonverbal body language can definitely help us in respect and empathy and gaining trust. The other thing in labor and delivery is some very intimate exams, right? We do some very personal assessments of their private areas. And we need to ask permission to do those things. And then we need to stop if asked to do so. And that's part of our trauma-informed care that, again, it's been a big aha moment for me. That wasn't the way I was taught, but it makes complete sense. And I have integrated that into my own practice. Hipaa is the protection. It's really encompassing a lot of things. It is supposed to be for electronic transmission of health information, but we kind of use it as an all-encompassing idea now. There are some exceptions to Hipaa. It's not if it's your best friend and you really want to know how her labor went. That's not an exception to Hipaa. It's not if your coworkers delivered already or not. That's not an exception. An exception would be mandatory reporting for abuse, an injury due to a weapon or criminal act, a threat to self, some specific infectious diseases, usually sexually transmitted, and a threat to an identifiable person. Those are reasons that we might need to discuss something outside of with just the patient. So when we're talking about education, I feel like this is one of the biggest things that we do for our families is educating them what to expect, signs and symptoms to report, the normal physiological process of things. But first, we need to assess what they know and what their culture has told them. And if they, what their reading level is, what their comfort is with the language that we're speaking. Those are all parts of the education process that sometimes get left out. I can't tell you how many times I've seen women that don't speak English handed English consent form. Does that make any sense? No. So we also need to plan mutually with our patient what it is that we're trying to get out of this education. So for instance, if I'm going to go in and give some discharge information to a mom that has come in for triage and she's not going to be staying with me, I have a goal of telling her what to expect and when she should come back. But if I am going to be giving her discharge instructions after she's had a baby, I have a goal of giving her the bare bones need to know information and then providing her some written information so she can look at it again if need be when she goes home because she's exhausted and doesn't have time for a full length course, right? Other things, other points about education is we need to slow down. And I know I'm talking fast because you guys don't like it when my lectures are long, but we need to slow down, repeat things that are very important. Sometimes you'll hear me stop and repeat the same sentence because then hopefully you'll listen, you'll hear it the second time. Speak in conversational style rather than I'm teaching you this, this, and this. You can turn it around and, well, sometimes what we see that moms like to do is this. And just change that type of education that you're giving to make it more easily received. And then we want to chunk that information into small bits. We're going to teach survival skills first, just like we do with nursing students, trying to teach survival skills. And then lots of pictures, illustrations, videos, color coding for those that have poor health literacy. We want to evaluate what they got out of our education, because if you just go in and spend a whole bunch of time spilling information out, you don't know that they actually got it back. So repeating, having them repeat the information back to you is one way. Open-ended questions like, so can you tell me what temperature it is that you need to report about this baby? And then maybe even give some pretend scenarios. You walk in, you find your baby is blue in the lips or mouth. What's the first thing you're going to do? And of course, documentation. That is one of the most important parts of any education that we give. We want to document so that we can tell other healthcare providers what it is that we have educated her on. And so there's a record of that education. And you want that for legal purposes too. So again, our role, provide resources, provide anticipatory guidance, what to expect, and education on what to do if things are normal and what to do if when things are not normal and who to report. We want to look at those resources and make sure that we are giving them good information. We apply the CRAP test to it. And we want to look in our own environment and look in our own groups to make sure that good information is being spread. I hope you've enjoyed this lecture. And if you have questions or comments, be sure that you put things down below and I will definitely answer them for you. Couple legal and ethical issues in maternal child health that we need to mention here. Abortion, such a hot political topic right now. I hesitate to even do it, but we do have to talk about it. So again, we come back to what I think is right for me. I don't get to decide what is right for you. That's my personal opinion. Substance abuse, sometimes we see substance abuse, and that is fetal injury potential. And we have to talk about what is the legal ramification for substance abuse. And there's all kinds of intrauterine therapy and things we can do to help our babies in utero. There's a lot of controversy surrounding that. When you do your readings in these chapters, you can see some of those things are mentioned. And then we have our maternal fetal conflict, which is beneficence versus autonomy. Like, when does the mother's responsibility to the fetus, like, how does that crossover happen? Because the fetus can't survive without the mother. But if the fetus is actually causing injury to the mother, there's that's a big complex issue. And we have ethics committees to help us look at some of these situations and really beyond what we're trying to discuss here, but we will fill some of this stuff in later. Informed consent, age of majority in most states is 18, but there are some circumstances that make these younger patients eligible to make their own decisions, and one of those is pregnancy. So if the mother is under 18, she does get to make decisions with pregnancy. And I'm going to go back to this slide for just a minute because there's something else I want to point out. As the nurse's responsibility for informed consent, that is the paper that the patient is signing, and they are stating that they got all the evidence about whatever proposed procedure it is. So they got the benefits of the procedure, they got the alternatives to that procedure, and then they got any risks to that procedure. The nurse's responsibility is to ensure that they sign the form. You're serving as a witness to that signature process, and then determining if they understand. If they do not understand, it goes back to the provider to come back and make sure that all of their questions are answered before they sign that form. And I already mentioned that under 18, they can make their own decisions. Also, all patients have a right to refuse. They have a right to refuse anything that we offer them. Parents sometimes have the right to refuse for their children, and there gets into a little bit of a conflict in some circumstances there, but parents do have a right to act in the best interest of that child. Okay, so you can tell that I thought it was over a few slides ago, but here we are. I hope that you have gotten a lot of need to know information out of this, where this is the introduction to the course, and we're going to keep uploading these videos over the next few weeks so that you'll have an entire new series to look at. If you have questions, whether you're a live student or in-person student, you're all live, in-person student or online student, put the questions in the comments. I'm happy to help, and I will put those guided notes down there. Thanks for watching.